Thank you everyone for attending the Early Childhood Voices Conference 2022. Today, I would like to present a study about efficacy of a self-directed video-based caregiver-implemented language program. Before I talk about the study, I would like to acknowledge my colleagues who contribute to the current study. They are Winnie, Gigi, Saira, Kevin, and Dr. Garrito. And my name is Cynthia. All of us are from the academic unit of Speech and Hearing Science at the University of Hong Kong. In today's presentation, I will start with a brief introduction of the study background and the research aims. Then I will present the two stages of the study separately, following with a general discussion of the whole study. Lastly, I would like to highlight the clinical implications for the current study for caregivers and the practitioners. A large amount of empirical evidence was found in supporting parents' important role in the development course of children with early speech and language difficulties. Thus, evidence-based language intervention often incorporate parents as the intervention agents. These parent-implemented interventions have been documented as an effective way to enhance the caregiver's responsiveness and their use of language facilitation strategies, in turn, to improve children's language and communication skills. In specific, research found that the knowledge in LFTs empowers the parents to modify the daily routine to fit their children's needs accordingly and boost their sense of self-efficacy in tackling the long-term problems caused by the language impairments. Results from the randomized control trial studies also indicate that effective use of gesture and different linguistic models, including self-talk, parallel talk, imitation, extension and expansion, observe and respond, was associated with better parent-child interactions and children's language and social outcomes. However, despite the compelling evidence of the effectiveness of these caregiver-implemented interventions, they have primarily been developed and carried out in the Western cultures. They have not yet been widely implemented or tested in some of the non-Western areas, including Hong Kong. The traditional one-to-one direct individual therapy is still the dominant model of the intervention here. In Hong Kong, the wide access of extensive use of internet-based technology provides the base of delivering parent training through telepractice. This modification of using telepractice instead of the traditional in-person training can further accommodate individual parents' needs, such as their irregular working schedule. In addition, adopting the self-directed learning methods, parents can learn based on their own pace and therefore may increase their training compliance. So in the current study, the research aim was to examine the feasibility and the efficacy of a self-directed video-based caregiver-implemented language program in Hong Kong. The self-directed learning model in the present study implies that it did not involve the use of instructors to provide feedbacks, and the caregivers were expected to learn on their own. The whole study consisted of two stages involving different participants and objectives. The research aim of stage 1 study was to explore the acceptability and effect of this self-directed program on families with children who have no clinical concerns. Stage 2 study extended stage 1 study onto families with children having language difficulties. The training program was developed based on the selected 5 LFTs, consisted of 6 video-based modules. 1 introduction video clips described the program's background, and 5 videos offer in-depth explanation and modeling on how to implement one LFT each. In addition to the video clips, a quiz containing 10 multiple choice questions were constructed in relation to the content of the videos to measure the caregiver's knowledge of LFTs. Stage 1 study was a single group pre and post design, consisted of 50 diets of typically developing children and their caregivers. Measures of the program efficacy include the program's acceptability, which reflected by the percentage of participants who complete the training out of the total number of participants who gave their written consent. Caregivers' knowledge of LFTs was assessed by the online quiz. Baseline and post-training videos of parent-child interactions were used for analysis of caregivers' effective use of LFTs, as well as the children's verbal communication ability. Intelligible verbal and nonverbal productions by the participating parent-child were transcribed and coded independently by 2 of the authors. 62% of the participants have completed the training in stage 1, which was comparable to other online parent training programs reported in the literature, reflecting the participating caregivers' general acceptance of the content of the training and its delivery mode. Regarding the LFT knowledge, caregivers obtain a significantly higher score in the post-training quiz than in the baseline. Parents' frequent use of gesture, imitation, and parallel talk in the post-training was significantly higher than those in the baseline. In addition, there was also a significant reduction in the post-training frequency of using directive. The significant gains suggest that this self-directed learning model appeared to be sufficient for supporting the parents to acquire and apply basic knowledge and techniques during the parent-child interactions. However, children's verbal production didn't show any differences between and after the training. It may be related to the selective outcome measure was not sensitive enough to capture the changes. And future investigation should also include more fine-grained measures for both verbal and nonverbal communicative acts. In general, the video-based self-learning model was found acceptable to general caregivers in Hong Kong. And these caregivers also shown gains in mastery of skills taught in the training. These preliminary results also permit an extended study on caregivers with more diverse attributes and those families with children having early speech and language difficulties. So in stage 2 study, we aimed to answer 2 research questions. First, for caregivers of children with language impairments, was the video-based program developed in stage 1 effective in increasing their knowledge and skills of using LFTs? Second, for children with language impairments, was the program effective in improving their language skills? Stage 2 study consisted of 49 diets of children with language difficulties and their caregivers. A pre and post between group design was adopted. Participants were randomly divided into 2 groups, the training group and the control group. The same set of outcome measures used in stage 1 study was administered in stage 2, except that children's vocalization and gesture were also included in addition to verbal production. The overall completion rate in stage 2 was 57%. It was slightly lower than in the stage 1. However, it should be noted that caregivers in stage 2 study were with more varied educational levels compared to stage 1. Most of the Stage 1 parents obtain higher educational levels. The diverse educational backgrounds and the diagnosis of children in Stage 2 study may be the possible factors that undermine the parental self-efficacy in the program completion. Regarding the LFT knowledge, caregivers in training group obtain significantly higher post-training quiz scores than the control group. Increasing trends of the use of parallel talk, expansion, and gestures were observed in the training group from baseline to post-training. However, these changes did not reach statistically significance when compared to the control group. Well, there were several plausible reasons for these findings. Compared to Stage 1 study, Stage 2 parents who were managing a child with speech and language difficulties may have potential high stress level. The high stress level and the more varied parental education background may affect their parental efficacy, in turn, influence their proficiency of acquiring the strategies. Moreover, children's weak verbal ability also contributes to the limited use of certain LFTs. Some children in Stage 2 study were still approaching single word and produce only vocalizations, which may not allow the caregivers to apply some of the more complex techniques like extension. On the other hand, significant growth in the children's vocalization were observed in Stage 2 study, which might suggest that the child's language outcome measure was sensitive to capture the changes compared to those used in Stage 1. Because there are several limitations in the current study, including the small sample size and the lack of control group in Stage 1. And for our future study direction, randomized control trial studies with a larger dosage in a longer time frame should be conducted to tap onto the long-term effects of such a program on children with language impairments. Factors that may affect the efficacy of the program should be taken into consideration when conducting the study. Comprehensive and sensitive measures, including standardized assessment, should be used as parent and child's outcome measures. In general, caregiver-implemented language program was a relatively new mode of training in Hong Kong. The current study further includes self-directed learning elements with the use of video clips in developing the program. Results suggest that such service delivery mode was generally acceptable and led to knowledge and skill gains in basic communication techniques among the Hong Kong Chinese caregivers. Moreover, these knowledge and skill gains reveal that the Western-based LFTs also works for Chinese caregivers. For clinicians, they may consider incorporating this training program into their routine therapy service for imparting information to the caregivers. They may also use this mode as a preventive measure in the early language development difficulties. And that's all for my presentation today. Thank you for listening.